Yeah, so the STAR was a very large academic UK-based study in 60 centres, and it was run through phase 2, phase 3 study, so all the numbers counted. So phase 2 was looking at feasibility and recruitment, and then the full phase 3. So what it was looking at is tyrosine kinase inhibitors, or TKIs, standardly given continuously until you progress on CT imaging, and it was looking at, because they have significant toxicity and cost, whether you could give them intermittently with treatment breaks to decrease that and have also cost savings. And I think what was unique about STAR was it was a large randomised study. There's been quite a few smaller phase 2 studies, and it also had a co-primary endpoint that looked at both survival and quality adjusted life years using EQ5D. A number of secondary outcome measures, I didn't present all of them at ESMO, and some translational endpoints as well. The key secondary ones we're presenting at ESMO looked at time to strategy failure and disease-free interval in the intermittent arm. So basically it was a study that recruited between 2012 and 2017 patients with pathology confirmed clear cell carcinoma of the kidney were randomised 1-to-1 to either continuous CCS or treatment break disease-free interval strategy. And they had Sunitinib, but when pazopanib became available standard in the UK, they could choose either drug or their clinician could. And for the first 24 weeks, both groups had the standard treatment. So the cycle was 6 weeks, but they had 4 cycles of treatment. And those that were still on treatment at 24 weeks took up their randomisation, which was either to continue the continuous arm till disease progression on the imaging, or on the intermittent arm to take up the treatment break and to go back on treatment on progression as RECIST on scan. And the ones on the treatment break could then have another 24 weeks of treatment, and they could have additional breaks. One was mandated, but they could have more depending on the discretion and the wishes of the investigator and the patient. So that was the treatment design. Basically, the baseline characteristics were well matched between the groups. Around 75% had had a prior nephrectomy, and there was the age and the number of PS1 patients reflected that it was a real-world UK population. And so looking at the data, the survival curves were almost superimposable when you look at the two arms. They were within a month of each other. There was hardly any difference at all. As a clinician, seeing those, you'd be happy to give either treatment strategy, and that was for the ITT and the PP population. However, when you look at the actual cutoff for this non-inferiority, it was met by the ITT, very narrowly missed by the PP population of 0.81 rather than 0.8. And that's probably because the study was slightly underpowered, because good news for clinicians, the survival has improved in the last 10 years with newer treatments, but very close to that. But obviously, from a clinical point of view, the trials were overlapping. If we looked at quality of life using the same approach, this was met for both the ITT and the per protocol population of non-inferiority. And although the health economic analysis is still ongoing, there were significant cost savings in the intermittent arm. And in terms of toxicity, there was less TKI-related serious adverse events in the TKI arm. Later duration for when patients needed a dose reduction or an interruption in treatment in the intermittent arm compared to the continuous arm. And there was highly significant better time to strategy failure. So in other words, patients stayed on TKI therapy for longer in the intermittent arm compared to the continuous arm, and the number of summative periods of disease-free survival. And so the conclusion was that treatment breaks were acceptable to patients and clinicians, were associated with cost savings. Interestingly, the number of patients who took one treatment break was the average, but 43% took 2 or more, and some took 6 to 9. So obviously it'd be interesting to look at the characteristics as we further analyse the data of that particular group that most benefit from a treatment break. And Although TKIs are still used first line, I think it's also relevant when we're looking at combinations with immunotherapy and TKI or second line TKI therapy.